Welcome, everybody. Lovely to have you with us this evening. Thanks so much for coming along. Some of you know me, but for those who don't, I'm Anna and I'm part of the support services team at Ovacome. So along with my colleagues Alice and Catherine, I'm there on the support service if you get in touch with us. And please do anything that you would like to talk through, any worries or concerns, also any information that you need, please do get in touch with us. We're available Monday to Friday, 10 a.m. to 5 p.m. And that's through the support line, email, instant chat through the website, text message. We can arrange video calls and schedule support calls with you as well. So hopefully, whichever way is your preferred way to get in touch, we've got a channel available for you. And please do contact us. We're here to support you and we'd really like to hear from you. So I'm delighted to welcome Barbara Milleret, who's the Senior Clinical Team Leader and a stoma care specialist nurse, to give the talk tonight on stoma care. Barbara sits on our expert advisory panel and she's been a huge support to us with our stoma support group that runs monthly. If anybody wants any information about that, please do get in touch with us, and also you can have a look at the website and the details for that stoma support group are on there. But Barbara volunteers her time really kindly with Ovacome, and we've benefited hugely, and our members with stomas have benefited hugely from all of her expertise. So we're really grateful for all the time that she continues to commit and share with us. And I will hand over to Barbara.
Lovely, thank you, Anna. As Anna mentioned, my name is Barbara Milleret. I'm a community stoma care nurse, and just recently more of a clinical team leader for Salt Healthcare, predominantly based in North London. So that's the area that I cover. I've been working with Ovacome for, I think it's coming up to 4 years now, and yeah, just really enjoy the interaction in the groups, and listening to everybody's stories and giving some advice and guidance when required. So obviously today is all about stoma care. It's about the ovarian, I suppose, pathway within stoma care, and how different aspects of it might affect you going through that pathway. First thing I wanted to talk about was just an introduction to the session looking at ovarian cancer. So there's about 8,000 cases of ovarian cancer a year. I'm obviously aware that these figures change all the time. So I do apologize if that's a bit outdated, but it has come from the recent cancer diagnosis. So from that, 92% arise from the ovary, and they've started to subcategorize into the fallopian tube, which is an 8% of ladies who present. Obviously, you know more about this than I do in terms of high grade versus low grade, and that obviously determines your treatment plan, your treatment options. I don't deem to know the oncology side of things in terms of gynae oncology, but I can certainly talk to you about stomas. So that's what we're going to try and focus on this evening. Obviously, with ovarian cancer, sometimes it may have spread to the surface of the bowel or the intestine. In these cases, in order to make sure that as much of the cancer as possible is removed, surgery may include removing a part of the bowel, and in turn, this will create the stoma. So I've put two pictures up of the most common stomas that we deal with. So the colostomy and the ileostomy. I'm hoping you can see them clearly, in that the colostomy is more of a left-sided stoma and the ileostomy is on the right side. I am going to talk about these in a bit more detail, because what we found is sometimes in the group is that people can get a little bit not confused, but they're very different. So the information and the guidance that we give to these stomas are quite different. So I just wanted to touch base on them a little bit, so as people know exactly with regards to their stoma, what stoma they have and what to be looking out for. So I've put a little agenda together. These are all the things that have come up through my discussions with Ovacome, but also the last couple are things that were discussed on the last support group meeting. So I've just added them in as an extra. So there was obviously the types of stomas, chemotherapy side effects, surgical side effects and how to manage them. So that was something that I thought might not be asked, but it was a question that somebody asked, and we will talk about them as well. Common problems with stomas and how to resolve them. So a bit like a hit list of what to do and where to go. One of the big questions, and I've spoken to Anna about this a lot, is why are gynae-oncology patients not cited or preoperatively assessed before the surgery? So that's something I just wanted to touch in on as well. Psychological consequences of having a stoma and going through the oncology side of things as well. We had pick versus port, which was a big thing the last meeting. Which one to go for? Who's advising? Why are they advising? How much choice do you have to decide which one you have, because they can impact on your particularly your swimming in terms of which one you choose, and obviously travel as well in terms of, you know, flushing and everything else like that. So that was something that was raised the last meeting, and obviously one of the big things is diet. I have touched a little bit on hernia as well, but I think we've done a separate hernia one. I don't know whether that's still available to view. So I thought I didn't want to go too much into the hernia side of things because it's already been done. But any questions on it, happy to answer. So the types of stoma. So the colostomy is the stoma that I just described on the left-hand side. It's made from your large bowel or your colon. Its appearance is much flatter and bigger than the ileostomy. It's got a formed output, so you should have some sort of activity in the bag 1 to 3 times a day of poo. It's a closed pouch, so there's no drainable part to it. And it's changed once it's full or half full, depending on what you want to do. There are 1-piece or 2-piece appliances on the market, but most of the UK use a 1-piece. So that basically means you take the backing off the bag and you stick it onto your tummy. As I say, the pouch is changed following bowel movement. It can be temporary or it can be permanent, and that is very much an individual thing, depending on what you've you know, what you've had the stoma in terms of how much of your bowel you've had to have removed and whether or not it can be reversed. I've put here some patients can irrigate their stoma. This is 1% of the population, and we discussed this the last time in one of the meetings, I think last time or the time before, and somebody asked about colonic stoma irrigation. From a professional point of view, you have to have consent from your consultant in order to even attempt to irrigate. You've got to be 6 months post-surgery in order to irrigate, and you've got to be not on any active treatment. So if you're on chemo, we don't really recommend it. So it's just something I want to touch on because it was a question that was asked previously. So that's the colostomy. I've got a little video here just to advise you on the anatomy side of it. So have a little look. This is 3D. It might give you this is just bowel, so there's no gynae organs in here at all, but it will show you exactly in terms of the bowel how and where they create these stomas. This is colostomy. I hope you can hear it.
The image illustrates the layout of your bowels and how surgery will affect their function. This is the small bowel, known as the ileum. This is the large bowel, known as the colon. This is the rectum. There are many different operations that may lead to you needing a colostomy. There are 2 main types of colostomies that are commonly formed, and it very much depends on your specific condition as to which you will need. Your stoma care nurse will discuss this with you in more detail. Here, in the sigmoid colon, is one of the most common positions for either an end or a loop colostomy. Another common position is on the transverse colon. It is more common to see a loop colostomy here. Here you can see the formation of an end colostomy. Please remember, it may not always be possible for the surgeon to position it here. Therefore, your stoma care nurse will discuss this with you before surgery. The image.
So that's a bit of a 3D image, and that goes down really well with some of our training, because I think you can see when it's rotating how the bowel actually, where the bowel sits and how it functions in terms of where it's connected to on the left and the right side. So that was a colostomy. Now we're moving on to the small bowel or the ileum. So these are sited mainly on the right-hand side of the tummy. So they protrude above skin level. So they've got a little spout on them in terms of they stand proud. So we don't want them to be flat. We need them to be proud, simply because they're dealing with more of a liquid output. So the consistency can be soft paste, porridge-like consistency. It functions throughout the day and the night, and it needs to be looked after slightly different to a colostomy in that it needs to be emptied 4 to 6 times in a 24-hour period. So therefore, the bag that people would wear with an ileostomy is a drainable pouch. You've got to be able to empty it, because if you would imagine 4 to 6 times a day trying to take that bag off your skin, it would cause lots of problems. So most of our patients with an ileostomy would change their bags every day or every 2 to 3 days, depending. If we've got young people who are going out to work and carrying on with their lives in terms of, you know, socially and everything else, we say to them, you can have a fresh bag every day. They're in the prescribing guidelines, so you should be able to do that. However, some people choose to leave it longer to try and protect their skin. So this is just the ileostomy. It's a very similar video, but just this is more focusing in on the ileostomy.
Illustrates the layout of your bowels and how surgery will affect their function. This is the small bowel, known as the ileum. This is the large bowel, known as the colon. This is the rectum. There are many different operations that may lead to you needing an ileostomy. Your stoma care nurse will discuss your specific surgery with you in more detail. The image you can now see is the most common position for either an end or a loop ileostomy to be situated. Here we can see the formation of an end ileostomy. Here we can see how a loop ileostomy is created. Both ileostomies, the loop and the end ileostomy, will necessitate the wearing of a drainable pouch, which is visible here.
So you can see the difference in the stomas in sizing in terms of one's on the left hand side and one's on the right hand side. So it does depend on. So when you go back to those videos, if you imagine encased in all of that bowel, you have your omentum and your peritoneum and everything else, and that's the bit that then focusing in on your situation where they have to strip and take some of that back. And sometimes it can be attached to the bowel, hence the need for the stoma. So looking at the chemotherapy side effects, these are just general ones. So these are ones that I wanted to focus in on as to how they're going to affect you living with a stoma. So things like your appetite, the sickness, if that happens, if you've got any weight loss, the fatigue, your increased risk of infection, just generally being on chemo, bleeding and bruising, which apparently some people look at me and say, well, how does that affect the stoma? It can cause issues around the stoma itself. And then the change in your bowel, you know, diarrhea, constipation, and obviously hair loss is in there, but that isn't actually going to affect your actual stoma itself. So I've just tried to highlight ones that will affect the stoma in terms of this. The slides are very busy, so just bear with me. So how can the side effects affect stoma function? So weight loss. If you have got weight loss issues or even weight gain issues during treatment because of steroids or anything like that, you do get some issues with the bags creasing, not sticking, leaking. And obviously if you've got sore skin or loose skin, sorry, you're going to end up with some sore skin underneath that bag. I am going to talk through these first, and then we're going to look at ideas to try and resolve them, because these are things that we come up with on the group sometimes, and it's just talking it through individually. One of the other things was the fatigue or the tiredness. I've put here inability to change the bag. I've been to home visits with people who have been floored by chemo and find it really difficult to even just physically manage the bag change. And that's a big thing for them because the lack of control is a big issue. And it's just trying to find some ways around how we can resolve this with family members, possibly helping. Sometimes we have to get some carers involved if patient lives on their own. So it can become a big issue with no energy, listlessness, and then low mood, and it all affects how that person's going to manage their stoma and their general oncology appointments and things. So it is important that we highlight that very quickly if that happens. Infection, obviously, higher risk of skin irritation, red sore skin around the stoma, and then that's when we need to add in some accessories and different products to try and help you get through that sore point. Bleeding and bruising does affect the stoma. So if you've got if you're on blood thinners or you're having any kind of anticoagulants, it increases the bleeding from the stoma itself. So the stoma is a very vascular part of your body. It's got a blood supply. So if you're on blood thinners, it can actually cause the stoma to bleed and can cause a lot of anxiety among patients when they see this level of blood coming from the stoma. We always say as long as it's not coming from inside and it's just on the outside when you're cleaning, then that is okay. We would expect that for that to happen. Bruising around the skin. Again, if you've got a real fragile skin base that you're sticking a bag to and you're putting a bit of pressure on that, it can cause bruising or a little purple ring around the skin. So diarrhea and constipation, I put down as a change in output from the stoma. So this may be that medication needs to be added in. We may need to look at the bag type that you're using. You may have then ballooning and pancaking on top of managing the day-to-day stoma. So ballooning and pancaking are two issues that can arise simply for the fact that you've got something covering your stoma. So it's all to do with the plastics in the bag. As much as they make them, really they're really up to date. There's new innovations in these bags all the time happening. There still is this issue with ballooning and pancaking. So lots of the bags have layers of plastic. So some of the bags have got 3 layers. So you can imagine you've got a bit of a vacuum going on then. So when you put it around your stoma, sometimes the plastic can stick and it can stick to the stoma itself and it can cause pancaking. So then when the poo comes out, it's got nowhere to go, only out the sides. So it causes leaks, basically. That's what pancaking is. And ballooning is the other extreme where you haven't got the vacuum, but you've got as if you've got a packet of crisps on an aeroplane and it's full of air. And you're struggling to manage how to expel that air, particularly if you're wearing a closed bag. How do you get rid of the air in the bag? And that's called ballooning. And there's different things that we do recommend, which I will come on to next slide, I think, as to how to manage them. One of the big things mentioned on the last meeting was hydration and issues with hydration. Anyone going through chemotherapy, particularly with an ileostomy, are going to have problems with hydration and should be treated in terms of, bloods need to be checked. They look at your kidney function. They make sure that you're absorbing what you're taking in. And we also recommend in the community where I work, we do recommend rehydration tabs or sachets. So you've got things like Diorolite, you've got St. Mark's solution, which is something you can make up yourself. Or there's a new thing on the market called ORS, ORS, and they're little tabs that you just drop into water and they're rehydration as well. We also recommend loperamide, and we always seek medical advice from either the oncology team or the GP, depending on who's most accessible with regards to the loperamide. We have got permission generally to start patients on a low dose. So if we've got a concern about one of our patients who've got a high output, having chemo with an ileostomy, we can just start them off on a lower dose, and then we would contact the GP or the oncology team to try and see whether we can increase that up and how often. The only thing I would say that if you were looking at products in terms of any of the issues, particularly, changing the bag type, pancaking or ballooning, just maybe seek advice from your stoma nurse first, because it might be that they've got something that is their go-to product. we've all got go-to products that we think, oh, this one will work. So it's always worth checking in first instead of you trying to navigate, the system in terms of all the different products that are there, because there's quite a lot and it can become quite frustrating. So don't be afraid to reach out, because that's what we're here for. That's what, if somebody rang me to discuss product changes because of issues, it would be samples straight away to try. So don't feel like you're bothering people. Do please reach out and ask. And I've just spotted a spelling mistake, so I'm going to move on. Surgical side effects. So obviously this was put in as a request. So wound healing, obviously, if you're on chemo, it will delay your wound healing. If you're struggling to eat, reduced nutritional intake also can delay wound healing and can lead to weight loss. So you can see the circle that's there. If all of these things don't work together, you can end up really having a difficult journey with this stoma. If your wound isn't healing, if your appetite's reduced, if you've got weight loss, it can then affect you socially and psychologically. So it's important from a health professional point of view to try and get all these things right for you at the first instance. So looking at wound healing, obviously, we can't always kind of prevent wound healing, but it's just being mindful that, when you're coming home, that you've got this wound, you need to be careful with it. You need to maybe not be lifting. You need to make sure that you're getting all the correct information on what you should and shouldn't be doing in terms of that. If you have got a wound that is open, obviously it will be looked after either by the district nurses, but a lot of areas now are bringing patients back into practices. So GP practices are doing most of the wound care, which is a big problem, because for some people, how do they get there? So it's very much looking at individualized care to see what we need to do to help people who have got wound issues, who are having chemo, or who may have a nutritional or reduced nutritional intake. I've put in the social and psychological isolation as a surgical side effect, simply because after surgery, people are at home. It can be quite isolating if they haven't got family around, they haven't got support network, they're relying on maybe friends or close family if they have family. But it's also nice for them to be signposted to support groups, hence the whole Ovacome. If they can get onto the internet. Some areas have got face-to-face general stoma care support groups. So it's always something that we look for when we're doing our first assessments on patients, to see what support they might need in terms of the social and psychological issues. So common stoma problems. So these are what we've just spoken about in terms of how are we going to manage them. So with sore skin, sometimes we look as a product change, not necessarily as the first line, but we definitely look at adding in some powder or some barrier wipes to try and support the patient with managing that sore skin. Sometimes it can be a simple thing as a template check. So the cutting, the size that the stoma bag is cut to. So it may be that you need to have a review of your stoma, or you can do a template check yourself with the little template cutting guides in the boxes. Most products have got them in there. If they haven't, you should be asking your stoma nurse, and they should be able to do a template check. So with leaks, we've said about why leaks happen. It could be the creases and the dips, loose skin, if you've had weight loss. What we tend to look at, or I tend to look at specifically with leaks, is whether or not we need to do a full bag change to something called convexity. So convex bag is something that you shouldn't be able to access unless your stoma nurse has advised it. It's basically a type of bag that causes a little bit more suction around the stoma, so it causes pressure and it could cause bruising. And it's not always appropriate for every person to use, although saying that, they do now soft convexity, and that's what we normally start people off on. So we would use a convex bag to prevent leaks, to help with leaks, but we might also use a seal with that convexity, depending on the patient, and also a little belt to wrap around the waist. Not a support belt, this is just a belt to hold the bag in place. I've got some pictures at the end of the presentation of some of the accessories that I've mentioned, so as you can actually see them, so as that you know exactly what I'm talking about. So inappropriate products, some people come out of hospital on completely the wrong product, and that is, that's what we have to deal with in terms of, getting them on the right products and making sure that they're not leaking, they haven't got sore skin. If you are 6 months down the line and you've not seen your stoma nurse, you are entitled to an annual review with the stoma care nurse. Most areas now would provide that, and most of them are done either in clinic or with a home visit. So as I said, don't be afraid to reach out to your stoma team. They can only say to you, this is how we do it in our area. It might be slightly different to how we do it in ours. So, don't be afraid to reach out. I mentioned ballooning. So with ballooning, I have a go-to product. I know which one I prefer to use. I'm not saying it works all the time, but equally, that's the one that I would offer samples to. We kind of have a list of which ones. So trialing new products is probably, if a patient's saying they're ballooning continually, they need to come off the bag they're on. You can try and try, but it's not working. For some reason, it's just not suiting them. So I normally offer a new product near enough straight away. We try and teach some filter control. So what that is, on a lot of bags now, they've got little filters at the top of the bag, and some of them have little tabs that you can cover the filter with for swimming and for bathing and showering. So the filter then becomes trying to keep it dry, basically. So if the filter becomes wet, it becomes problematic and it can cause problems. So I do offer to show people how to use the filter. Some people like the filter using the tabs and others don't. So it's so individual. But I would say to you, if you're ballooning and it's a real problem, just keep persevering with trying different products, because you will find something that helps, or with some techniques that help as well. With ballooning, some people avoid, sometimes have to look at their diet to see whether or not it's something that they're eating is causing so much wind or gas in the bowel. So we do ask people who are ballooning as well to sometimes keep a food diary, just so as we can see what they're eating, see if that's causing the excess. Pancaking is, as I say, the opposite. So it's when there's no air in the bag, or there's no wind being produced. Well, there is, but it's just not staying in the bag, and the filter is allowing it to escape. So what we tend to do is we try and separate the plastics inside the bag. So we would lubricate the inside of the bag with some baby oil. So you put little drops, 3 drops of baby oil into the bag before you take the backing off, because you don't want to get the oil on the backing, because else it won't stick to your tummy. And we try and keep air in the bag. So some people put a little bit of rolled up tissue at the bottom just to keep the plastic separated. And sometimes that helps, but the lubrication of the bag certainly does help. It's very difficult to completely get rid of pancaking, because pancaking is a consequence of the consistency of your stool. So it's what's coming out. So obviously we can give advice and guidance, but I can change the consistency of your stool in terms of what's happening internally, apart from adding in, possibly with pancaking, we might add in something like Senecot just to loosen it a little bit and make it more watery. That's the only thing we can do with pancaking. But again, it's worth a conversation. Don't suffer in silence. If it's happening, please reach out. And again, what Anna said, if there's people who haven't got active stoma nurses in their area and they want to pass some questions on these, happily send them across, and I'll try my best to get some information for you on them. Stoma, some other common problems people say to me is, I can smell the bag, I can smell it, it's there, I shouldn't smell it, should I? And it's like, no, you shouldn't smell it. If you smell the bag or your stoma or poo, then something's not quite right. In terms of the bag, it's failed. So the bag is either allowing air to come through the filter and not deodorizing it, because the filters are carbon, so it should allow the deodorizing carbon filter to work. If you can smell poo, then there might be a leak. So I would always say, please, if you're having smell and you can smell the bag, then you need to, again, have some advice on whether or not you need to change products. Obviously, as you ladies know, the bag is literally sat under your nose, and I can imagine from that point of view, as soon as there was a problem, you would smell it, and you're hyper aware of it. So just be mindful that you can buy things over the counter and not on prescription in most areas. Deodorant drops, so they're like little oil drops that you drop either into the bag, and they smell of, like, I don't know, there's one tangerine and there's one blackberry and blueberry. But obviously they're not on prescription. Most of them would be rejected if you try and request them on prescription, but you can buy them. But I would say I would ask for a stoma care nurse review if that's happening, just to make sure that you're on the right product. Creases and dips, like I've mentioned. So for me, that's a complete product review. Seals and paste, possibly. So seals are like the little washers. Some people call them seals, some people call them washers, some people call them donuts. They're all different names. And there are loads of different brands. So it's just getting the right one to work for you. And what we try and do with creases and dips is we try and flatten the area so to create a flatter surface for the bag to stick on. And that's why we would add in the seals and the paste. So weight loss or weight gain, for us in our area, if somebody's having major weight loss, we always tend to have to do the review because they need convex bags. So we have to be able to physically see them in order to assess that. And the same with hernia. So if somebody rings me to say that they think they've got a hernia, first of all, we tend to get photographic evidence if we can from the patient sent across to us. Then we would look at whether or not we refer them for some support underwear. This is a bit of a bone of contention in some areas because hernia support wear is available now only on level 3. So level 3 support wear is when you have a confirmed diagnosis of a hernia. So you need the support wear. We used to be able to get level 1 and level 2, which is very light support wear. But the NHS has pulled back completely now and said, no, patients have to buy that themselves. So we tend to refer to support underwear companies once we've seen a photo of the hernia or we've physically seen it ourselves. And then we look at different bag types. There's a new product, actually not that new, but it's newish, called Concave. So it's basically the opposite to convex. So it cups the hernia and it provides a little bit more support around the bulbous area of the hernia. It doesn't suit everybody, but it's definitely there in the market. And it can be requested as samples again from your stoma care nurse. Again, high output, especially on chemotherapy, or even not. Some patients just unfortunately suffer from high output. High output is basically where your ileostomy in particular is draining lots and lots and lots of fluid through the stoma. So as much as you're trying to keep yourself hydrated, you're not absorbing anything and it's coming straight out the other end into the stoma bag. So with those patients, obviously they would be on regular bloods, looking at kidney function to make sure that there's no issues with the kidneys. Rehydration tabs or St. Mark's solution or diaurolite. And I would always ask patients to seek medical advice. I think one of the meetings last month or the month before, that was the advice I gave. I really felt that this lady who was on the group needed to seek medical advice, and I'm hoping that's what she's done. Because what she was saying was very much she had a high output. And that was just from, virtually on the group having a chat and stuff. So it is important because what can happen is if you've got a high output stoma and you can't resolve it yourself at home, you end up damaging your kidneys. So you need to get medical advice in that situation. This is the big thing for me, and I couldn't quite understand it when I first started dipping in with Ovacome a bit, was why are our ladies not pre-opt and cited? So colorectal, which is bowel cancer patients, receive as standard pre-op counselling and citing. We get the referral through, they're going to have X, Y, and Z. Please, can you see them, talk through everything, and then put the mark on their tummy? So my question was, why does this not happen for the gynae oncology patients? And what I've kind of come up with, and Anna, you can correct me if I'm wrong in terms of some of this information, but it's not always that it's a solid tumor that is in, you know, in the area that the surgeon's dealing with. And sometimes the seedlings are attached to the omentum and the peritoneum. So that part of the bowel that you saw in the 3D, that's encased in your omentum and your peritoneum are all encasing it. So they have to strip it back. And then obviously they get to that point where they think, oh, actually, there's a little bit there that I need to deal with on the bowel. So it doesn't show up on scans, as far as I'm aware, in terms of all of these little seedling areas. So therefore, it's really hard to plan. Surgeons, in their defense, do try and avoid a stoma formation, but equally, I just feel by not citing and doing a pre-op, are we doing a bit of a disservice to you ladies who now have stomas, who haven't had the luxury of meeting the stoma nurse beforehand. I was trying to find out kind of statistics, but there isn't any. I couldn't find anything to say as to why or how many patients come back with a stoma who are going for ovarian surgery. And I just think the general consensus is that you would prefer to be cited and counselled instead of waking up with a stoma. That's just my own kind of opinion. And I just thought maybe further research would be needed on that. And it's something maybe that, you know, stoma nurses could look into to see why in some centres they're cited and some not, in relation to I think because pre-op citing is so important from a psychological point of view, from an information giving point of view, from where the stoma is going to be situated point of view. You know, we've had a lot of feedback to say, I just had a brief conversation in theatres before I was anaesthetised. You know, I would hope to think that that's not common, but it has been mentioned in some of the meetings. So that's just something that I've kind of brought into it because it was asked as a question, why aren't we cited and pre-opt? And it is a small proportion of patients who will come back post-surgery with a stoma, but still it's a proportion. And, you know, I think it needs to be looked at in terms of, you know, even within the gynae-oncology nursing forums, maybe, I don't know, something to bring forward just to say it's been recognized. Psychological signposting. So this is a big thing for us currently. Health and well-being is massive on everybody's agenda, be it the NHS or Ovacome or us within, you know, community services, within Souls Healthcare, who I work for. It's massive, not just obviously health and well-being of our patients, but obviously of ourselves as well. So there's been a lot going on in the background in terms of support. Ovacome obviously is very much present and there and available. Macmillan Services, you know, when I worked in the hospital, that's who we would refer everybody to Macmillan. That was our go-to. So they're very much still available, and a lot of our patients will have the Macmillan information sheets when they come home from general colorectal surgery. Obviously, from an Ovacome point of view, I think once they tap in, they get a lot of their information from the website. Stoma companies, so patient leaflets and advice. There's loads out there now. They're all doing all sorts of things. They're doing breath work, they're doing yoga, Pilates online. We've had something with Ovacome a while back with our exercising, deep breathing, post-operative kind of stuff. So the stuff, it's there to be looked at. It's just sometimes you have to go searching. A lot of stuff now online has got QR codes, so you have to scan to get into it, in terms of getting the right information. And we've also started to look at patient advocates. And I'm not sure whether Ovacome have looked at this in terms of, you know, advocacy in general, but in stoma care in general, it's a big thing now. We've got lots of advocates, lots of ambassadors, you know, befriending services, buddies, all sorts, call it what you want. They're there for support. And obviously through some of the other general stoma care support groups like Colostomy UK and Ileostomy UK, they'd have befriending services. So Most of it's done virtually now, I think, or through telephone or online, but they've all had well, they should be DBS checked before they're referred to anybody. So there are people out there that you can speak to. Counselling services, I've put this in because this was a big thing in COVID. People didn't know where to access or how to access counselling, like official counselling services if you want. But you can access a lot through the NHS websites now where you self-register, and they say it's a 12-week wait. I don't know if that's the case, but that's what they're saying on the website. So you don't necessarily have to go knocking on your GP's door to say, I need referral. You can do it yourself online. Support groups, obviously, which is this one, and so which is online, but we also have local and face-to-face ones, in some areas, generalistic stoma care support groups, not necessarily just ovarian or Ovacome, and they can be helpful if you find a good one as well that's well run. Stoma care nurses, obviously, your oncology nurse. Within my nurse team at the minute, we've been looking at tapping as a quick fix for our new post-op patients. So it's basically once you're home and you're recovering in the first couple of weeks when we see you, I haven't done it yet because I haven't had time to train it, but I am going to learn. They're doing these 10-minute quick fix tapping sessions with the patients, show them how to do it. And it's really, really gone down well with that group of patients. So it might be something to look into in terms of going forward with supporting patients, or even a virtual tapping group. I don't know, just something else to add in, Anna, to the equation. Mindfulness, health and well-being, breath work, all of that. I think everyone's much more aware of that nowadays, and it's much more acceptable to say that you're seeing people to help you with that, because it does help with the anxiety and the psychological issues that may arise. I've put open days, which are more stoma product related, because obviously if you have leaks affecting you psychologically, then open days might be the place where you go and meet all the different companies with all the different products, and then you try them. And I've just said GP and local mental health services because they are still there, as much as how accessible the GP is always a bone of contention post COVID. But obviously if you're in if you've gone from psychological issues to what you think may be more mental health service related issues, then you do need to go to your GP and you do need to reach out to them for specialist help. And I've just said, and you can refer from the counselling on the NHS website. Issues raised in Ovacome support groups. Sorry, and I'm already at the time. I'm just going to run through this really quick because it did come up. PICC line versus port, advantages and disadvantages. So obviously you ladies know more about these because you are the ones who have them, but the PICC line can stay in for weeks and months, and the port can stay in for years. That's my understanding. The PICC line obviously it's outside the body and has a lumen, which is a higher risk of infection, and the port is inside the body, which is less risk. One of the reasons we discussed this was swimming, and that's a definite no-no with the PICC line, so no swimming. And I think one of the ladies said that was part of her recovery process. She needed to be able to do her swimming. So it was discussed with our oncology team as to what was the best option for her. So, I think a port was then the option. So I think it's just been able to have a bit of choice in that if that's your thing and you want to be able to swim, a stoma bag won't stop you from swimming. It'll be whether or not you've got the PICC, and that would be. So I think that's important just to highlight that. There is dietary differences between the ileostomy and colostomy. There's a lot of information online, and I haven't gone into it again. That's nearly another webinar. It's too much information in one hit. So I think if there was something relating to diet, I can always send the dietary. I think we've done the dietary advice one as well, and I didn't we, Christmas one at some point, do's and don'ts. So it might be that can be shared again, or I can send that back over and stuff. And also issues raised again with stoma care services nationally or locally can be quite different in different areas, a bit like postcode lottery, whether you've got community stoma nurse or whether you've got the hospital-based one, whether you see them, whether they're hard to track down, formularies, which guide us on what we can prescribe, basically. So a bit like the drops for the deodorizing drops, we can't prescribe them. So they're starting to clamp down a little bit on certain products within the formulary. So just be mindful of that. If that's said to you, you can't have that because it's on a formulary. That's what it means. It means that they've tightened things down a little bit financially in the NHS. And then there's all the whole issue of sponsored nurses, company nurses, you know, who do you fall under? Should it matter where you get supplies from? And they were just issues that were generally raised. But at the end of the day, we're all very much clinical nurse specialists, and we all work to our code of conduct. So it doesn't matter who you work for or whether you're NHS or sponsored, we should all be given the same level of care. And I've just put the hernia again at the bottom because has been raised as to getting support underwear, where to go, who's the best ones to use, that kind of thing. So we can certainly talk about it again if needs be. I have got a presentation that I could share with Anna again if you wanted to look at that. But that I said, diet and hernias are nearly two separate things in terms of information giving. And then there's just the picture of the product. So these are kind of, and it's also got the St. Mark's solution at the end, so as you can see exactly what you need in terms of ingredients for St. Mark's. If you've got a high output stoma, you've got your closed bags at the top, you've got your drainable just beside it, and then just tucked in the back of it is the convex, where you can see it's slightly raised, the base plate. You've got your protect wipes, you've got your support band, that's paste, Convatex stoma adhesive paste. You've got adhesive remover, you've got your little ring powder. So these are all the basic stuff that we would offer to patients in terms of support. And then we've got the little belt at the bottom where it says adjustable ostomy belt. They're the ones that can attach to the bags to give a little bit more tightness around the tummy. And thank you for listening. And have we got any questions? I think I've done all right for time.
Yes, fantastic. Thank you, Barbara. We do have questions. If anyone wants to drop any questions in, as I said at the beginning, to the chat or the Q&A box, please do. We may not have time for all of them, but as I mentioned, Barbara's very kindly said that she will respond to them afterwards. So, so please do drop them in and we'll take a note of them all. So Barbara, questions come in and it says, after extensive surgery for advanced ovarian cancer, colon resection, removal of caseum, appendix, omentum, debulking tumours, etc., I have a colostomy which is attached to a colon stump, only mucus output and a functioning ileostomy. I manage the ileostomy well as a rule, but I'm aware I don't want to develop hernias. I've been given level 3 belts, but find that wearing one for a while causes leakage due to the belt washing the stoma bag. Any advice? My cancer is now resistant to chemo and no further treatment is planned.
Okay. Yeah, so that's quite extensive surgery, isn't it? So the problem with this lady is that she's got two stomas, if you like. So we would sometimes recommend that you would cut a hole in, or the companies would cut a hole in the bag, in the belt, to allow the bag to sit on the outside to stop that squashing. The problem with that is you're losing some of the support. So you're losing some of the level 3 support. It might be worth going back to that company to see whether or not they would recommend, or the belt fitter would recommend, assuming it was a complete it was a bespoke belt fitting that somebody came to see you to do that. You can get the hole cut, I suppose, on just the ileostomy side. If the mucus fistula is not causing any problems, just leave that under the support wear, and then with the ileostomy, the bag can sit on the outside. They reinforce it, so they put a ring of plastic reinforcement or the extra stitching around it, so as it tries to keep some of the support. But that's what we've had to do. We've had to have holes made in some of the support garments to support that, because you don't want to be leaking. You can't be leaking, really. It's not ideal.
Thank you, Barbara. So another question. I have an ileostomy and the output is very variable depending on what I eat, but recently needed a large dose of amoxicillin, 1 gram 3 times a day for 7 days for pneumonia, which fortunately didn't affect the output too badly, but certain foods, e.g. blue soft cheese, makes it poor brown liquid. So now not eating those. My question is, could I take something like Imodium before or after eating a nice soft blue cheese to prevent the drainable bag being unable to cope, especially at night?
Yeah, you can. You can. Some people take Imodium just to go traveling with in terms of slowing down their output. So there's no, it doesn't interact with any medications really in terms of, taking it for that, short period of time should be okay. So yeah, you could try it and see if it works, and if it helps, and you can have your nice soft cheese. That should be okay.
Fantastic. Thank you, Barbara. If there's any other questions for Barbara, then please do drop them either in the Q&A or the chat box. And just while we're waiting for those to come in, I did just want to let people know, so I'll just mention that the time of recording for this is June 2024. So for anybody watching this as a recording later, this won't necessarily be relevant. But for those of you who are watching live or close to the time, I just want to let you know that NICE, which is the National Institute for Health and Care Excellence, are undertaking an assessment looking at one-piece closed stoma bags for adults with a colostomy. So we'll be contributing to that, and we really want to share the experiences and views of the community who use those bags as part of their treatment for ovarian cancer and managing their stoma. So if you're interested in having your experiences shared, then we'd really like to hear from you. We will be doing an online focus group on the 13th of June, but also you can just contact us in the support team. So please do let us know if you'd like to take part. We'll circulate the details for that, but that's just an opportunity to share your experiences to help inform that NICE assessment. As Barbara was saying, that feeds into the NHS provision and understanding of what it's like to live with a stoma, and particularly in using those one-piece closed bags. So please do get in contact with us. Oh, I thought we had another question, so I was rushing through that a bit, but it was just say, so I said, thank you very much for your advice about the blue cheese, Barbara.
Oh, that's fine, yeah. And I just wanted to reiterate, Anna, about the NICE consultation. It's really important because products could be lost along the way if we don't get this right with NICE, because they don't, I'm not saying they don't understand. They're not patients and they're not clinicians in stoma care. So they need to get this right. So it's very important.
Yeah, absolutely. And as I say, if anyone wants more information on that, please do get in touch with us. But we'll circulate this recording and we'll circulate those details as well to you. But please do, if there's anything that you'd like to share about your experience with those bags, then please do let us know. So any other questions for Barbara at all? I think it was such a comprehensive talk, Barbara. Thank you so much. Was there anything that you wanted to add in at all? And just while we allow people those few minutes, if they've got any.
Yeah, it was just to say it would be really interesting from your members about this pre-op and sighting thing. It's because it's really kind of relevant. It's so important, and I just think that, even if there was a query as to having a stoma, why would you not prepare somebody? Why would somebody not be informed? That's my kind of take on it. But it would be good to know the percentages of who's been pre-opt and who hasn't.
Yeah,
it's something that you'd like to take on, Anna, for future.
No, thanks, Barbara. I'll feed that back to the team as to whether there's a piece of work that we do around that. But also, if anyone wants to share information about their experience with that for us to then pass on to Barbara, we can do it anonymously, but as a sort of general experience for Barbara's information, then we can do that. But absolutely, I'll take that back to the wider team as well. Great. Oh, we've got okay, yeah, and exactly what you were saying, Barbara. Someone's just commented that her experience was that the pre-op sighting was invaluable in helping her prepare for the fact that that she would have a stoma.
Yeah. Good.
Any questions for Barbara before we finish? Okay, well, we're nearly at the end of our time, so I'll just ask Rebecca to come back, and Rebecca, if there's anything that you wanted to mention to people before we finish, and then we'll draw this webinar to a close. But thank you so much, Barbara.
Thank you.
Oh, Rebecca, you're muted, sorry.
Oh yeah, no, nothing from me. Yeah, thank you. Really, really informative, Barbara. Yeah, I've learned a lot. Thank you.
Well, thanks ever so much, everybody, and please do get in touch with us. Anything at all we can help with, any questions, then please do let us know.